Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about some of the key news stories affecting primary care. Coming up, we're talking about what's going on with physician associates after the BMA issued new guidance on the tasks PAs should and shouldn't be doing in the NHS, and the RCGP updated its red lines on the use of PAs in general practice. We're talking again about the struggles GPs are facing finding work as the financial pressures in general practice continue to bite, and the results of a new BMA survey of GP registrars about their future career intentions. And we'll be looking at what went on at the Welsh LMCs conference recently, where GPs called for the BMA to move towards industrial action by GPs in Wales, and also what's going on in England as we head towards the end of the referendum on the GP contract. That's all to come on this week's Talking General Practice. First up, we're talking about physicians' associates, or PAs, and there's been a number of developments on this in the past couple of weeks, so we're going to talk about each of them in turn. But Nick, first, it may be worth doing a bit of a recap about why this is an issue and where we are now.
Yeah, so physician associates are one of the staff groups that have come into the general practice workforce through the Additional Roles Reimbursement Scheme, the ARRS. More than 3,000 of these staff are currently employed through primary care networks. And the NHS Long-Term Workforce Plan, published last year, suggested that in just over a decade from now, there could be around 10,000 physician associates working in primary and mental health care in England. The Workforce Plan says PAs are medically trained generalist healthcare professionals with an undergraduate degree in a life science and/or a significant background in healthcare. But there's a real lack of clarity and consensus around the scope of practice that staff in these roles should be expected to take on. And over the past year or so, this issue has really blown up. Last September, the BMA put out a position statement on PAs, and that raised concerns about blurring the distinction between doctors and non-doctors, and it said that PAs should not be regulated by the GMC because that would add to confusion. It also said they shouldn't ever be handed the power to prescribe, and it warned that patients are really confused by the name physician associate, in some cases thinking it sounds more senior than a GP, for example. And the BMA's campaigned hard in recent months to try and stop legislation going through Parliament to make the GMC responsible for regulating PAs. But that legislation has now gone through both the House of Commons and the House of Lords, and it'll soon become law. So the government's just pressing ahead with plans to expand the roles of physician associates, despite polling by the BMA that shows 9 in 10 doctors think the way these staff are used currently in the health service is unsafe. Most doctors also say that working with PAs has added to their workload because of the supervision they need. And that's the diametric opposite of the reason they were introduced, which was to reduce pressure on doctors. One story we published a few weeks ago that I think really captured how doctors' views are being ignored on this issue was around comments from a Conservative member of the House of Lords. He's also a former health minister, Lord Bethell. He said that opposition to PAs was Luddism, and that anyway, most work GPs do is incredibly straightforward. There's a real fundamental misunderstanding of the complexity GPs face on a daily basis and the management of risk involved in seeing undifferentiated patients, and the way that the broad training GPs have equips them to know when the person sitting in front of them does actually have a straightforward issue, and also to pick out when in fact it's something more. And I think it's also worth mentioning here that none of these issues I've been talking about are actually the fault of physician associates themselves. The problems here are all about the fact that these roles have been introduced into the general practice workforce without proper agreement around what it's safe for them to do and how they fit into the existing healthcare framework. And this is at a time when underfunding in general practice and the wider NHS has caused real problems, many of which we've obviously discussed on the podcast repeatedly. And as a result, staff already in these roles and currently training to become PAs are caught in a really horrible situation that, as I say, is not of their making.
You quite neatly summarised a lot of the concerns that the BMA has about the PA role there. And so 2 weeks ago, around the time we recorded the last news podcast, the BMA actually issued guidance on physicians' associates. That guidance is called Safe Scope of Practice for Medical Associate Professionals, or MAPS, and MAPS cover physicians' associates, anaesthesia associates and surgical care practitioners, all of which are roles that have been created to support doctors and which should be supervised by doctors. And many doctors have been calling for a clear scope of practice for these MAP roles, so it is totally clear what they should and shouldn't be doing. A lot of people think that this should be the GMC's job, but the GMC says that it's actually up to employers to define the scope of practice that their PAs, AAs or SCPs work under. The BMA, for its part, says that that's completely inappropriate because it will just lead to more confusion about what these roles should and shouldn't be doing, which will increase patient confusion and runs the risk of unsafe practices occurring. So this guidance that the BMA has put together is aiming to address that gap there and set out the scope of practice which it believes it's safe for these roles to do. The BMA says that employers, which include practices and primary care networks, should be using this guidance now to help ensure that they're providing safe care. So what it does is this guidance basically provides a traffic light guide showing what PAs are expected to do, so green things, what they can do under the direct supervision of a doctor, so what they're calling amber, and what they should never do, so red things. And there's a traffic light guide for each specialty where these roles work, and also some general recommendations around supervision for doctors who are overseeing PAs. In terms of general practice, the key thing the guidance says is that physicians' associates should not be seeing undifferentiated patients. So basically, they should never be seeing patients who haven't already been seen and assessed by a doctor and following a treatment plan initiated by a doctor. Physicians' associates also need to have a named supervisor who should be on the premises when they're working. And if that doctor isn't working on that specific day, they should have another named doctor supervising them. Again, that person needs to be on the premises, not at the end of a phone call. So that scope of practice is very clear and it's quite useful. It's got very specific tasks which PAs can do under supervision, shouldn't be doing at all in general practice. But what's kind of especially interesting about it, and something that we picked up on when we were writing about this, is that some of this guidance is actually totally opposite how NHS England says the role should be used. So as you say, Nick, PAs are primarily employed in primary care via the Additional Roles Reimbursement Scheme, which is a key plank of the network contract DES. So this is the contract which primary care networks operate under. And in that contract, there's what's called minimum role requirements for each of the roles funded by the ARRS, which sets out the training these staff should have and then the key responsibilities they should undertake if they're employed under the ARRS. And for PAs, the first responsibility the contract says is that they should be providing first point of contact care for patients presenting with undifferentiated, undiagnosed problems using history-taking, physical examination and clinical decision-making skills to establish a working diagnosis and a management plan in partnership with the patients. So that is effectively a contractual requirement and has been since PAs were added to the ARRS in 2020. Now, obviously, if you look at the BMA guidance, it clearly states PAs should not be doing any of those things. It says that PAs should never see undifferentiated patients. They should never be making independent decisions about initial management or ongoing care of patients. The BMA guidance is really explicit that PAs must always work under the supervision and direction of a doctor, that it's an assistant role to help support doctors, and in general practice they should only be seeing patients who have been triaged by a GP and where there is an appropriate protocol in place for them to follow. So there's a real conflict there, and the BMA has actually called for the network contract DES to be changed to reflect its advice. The BMA's GP committee in England has also said it's going to be producing some more detailed guidance for GPs and PCNs about the use of PAs in general practice next month in April, which could well be coming out, I guess, around the time all the guidance the BMA usually puts out every year relating to the GP contract.
Just in terms of the significance of the BMA guidance, at the press conference to launch it at BMA House, there was an appearance from the parents of a woman called Emily Chesterton, who we've mentioned before on the podcast. So Emily died in late 2022 at the age of 30 after developing a pulmonary embolism. She'd been for 2 consultations with a PA, and she'd been told that she had anxiety and possible long COVID. Emily's parents believe that if the BMA guidance had been in place earlier, their daughter would still be alive because she would have seen a doctor who would have been more likely to pick up the real problem. Clearly, GPs can make mistakes too in diagnosing patients, but this case is seen as one that really highlights the potential risks of having staff who are not trained to the level that a GP has been, seeing undifferentiated patients and perhaps without close enough supervision.
We're going to come on to talk a bit about what NHS England has had to say about all of this in a minute, but there's also been some development on PAs from the RCGP as well. The day after that guidance from the BMA came out, the Royal College of GPs held its scheduled council meeting, and one of the topics up for discussion at that meeting was physician associates and the role they play in general practice. Nick, you were looking at that. What came out of that meeting?
The RCGP actually published a list of red lines around the use of physician associates in general practice at the time of its annual conference towards the end of last year. And it's now decided to expand that list a bit. And the College Council has also raised a string of concerns around physician associates, some of which reflect the BMA points that you've been talking through. The original red lines around PAs from the RCGP said they should always work under GP supervision, should never be used as substitutes for or to replace GPs, and that they should be regulated with properly designed training and a drive to help the public understand their role. The college has now added 2 further points to these red lines. So they now say that funding and resources in general practice should be prioritised for training and retaining GPs, which implies a concern that some of this could be lost to training for PAs in general practice. And the final point added to the red lines is that the responsibility and skills required from GPs to supervise PAs have to be properly recognised and funded. And crucially, that GPs should not be forced to take on supervision of these staff, and that if sufficient supervision isn't possible, PAs simply shouldn't be hired. The college said also that there were significant concerns from its members about plans for the GMC to regulate PAs, which we've talked about just now, and its council's now moved its stance to calling for a different body, such as the Health and Care Professions Council, to take on that role, which is much like the BMA position. The college is also planning to run a consultation of its members in the coming weeks on the role of PAs in general practice, including around their scope of practice and how supervision works, and has said that will feed into new guidance that it'll put out sometime in the future.
What's NHS England think about all of this?
So interestingly, NHS England said last week that it would produce clear guidance on the use of physician associates in general practice, and that the BMA guidance would feed into that. NHS England didn't respond to a point that I put to them about whether they agreed with the BMA stance that PAs should never see undifferentiated patients. So, remains to be seen what sort of stance that NHS advice will take and whether it ultimately is acceptable to the profession. But what NHS England said its new guidance would do is to help trusts and GP practices to ensure that physician associates are working safely and effectively within their scope of practice. That sounds a bit like an admission that to date it hasn't produced clear advice on safe limits around what physician associates can do and how they should be supervised. And given that PAs have been coming into general practice through the Additional Roles Reimbursement Scheme for several years now, that's potentially a pretty staggering admission. Anyway, advice to come from NHS England on physician associates in general practice, and that's to be welcomed. But it's also clearly something that should have been in place and crystal clear from the outset.
Actually was some new guidance from NHS England that came out last week as well relating to PAs. It was more specifically aimed at hospitals. We've been talking very much here about PAs in general practice, but obviously there's a lot of PAs in hospitals as well. But some of that guidance is relevant for primary care as well. That NHS England guidance basically said that PAs should never be used as a replacement for doctors, and more specifically it said that PAs should be not used as a replacement for doctors on hospital rotas. Yeah, interestingly, in the wake of that guidance coming out, the Telegraph newspaper published an investigation, which it had obviously already been working on, and that investigation found that rotas at more than 30 hospitals in England showed PAs were in fact taking on hospital shifts that were earmarked for doctors. That story led the BMA to call on the Health and Social Care Secretary to launch an official independent inquiry into the use of physicians' associates in hospital, which it said was needed to uncover the full extent of what it called a patient safety scandal. Something else that's worth mentioning here, because people listening might well have heard about this as well, there's a lot of things going on around physicians' associates at the Royal College of Physicians, and I think that it's fair to say there's quite a lot of controversy around how the RCP, the Royal College of Physicians, is handling its members' concerns about the use of PAs. I mean, one thing to note about this is that the Royal College of Physicians actually hosts the Faculty of Physicians' Associates, which is the professional membership body for PAs. But anyway, the RCP held an extraordinary general meeting last week to debate some of the issues around the use of PAs. This was a meeting that had really been forced by members. Ahead of that meeting, the college surveyed members about whether they felt PAs impacted on training opportunities for doctors, how they felt about PAs being part of a multidisciplinary team, whether they thought doctors and PAs were properly supervised and supported, and how well understood the term PA was within their team. And there's been a lot of unhappiness about how that meeting was handled. Some of the concern has come from the way that that survey data was presented at the meeting. And as a result of complaints, the college has actually published the full results of that survey. And when you look at those results, it is quite clear that there is a lot of concern from Royal College Physician members on all of those questions they were asked, all of those things I just mentioned. Also, a lot of unhappiness about how that meeting was run, whether people's concerns were adequately listened to. And the RCP has come in for a lot of criticism on social media about all of this. So the Royal College of Physicians is holding a ballot of its fellows on the 5 motions it debated at that meeting, which closed this week, and the results are expected to be published next week. Those motions relate to things around scope of practice, generating an evidence base and an evaluation framework around the introduction of PAs, the impact PAs have had on training opportunities for doctors, and also one motion that calls on the college to limit the pace and scale of the rollout of physicians' associates until some of these concerns we've been talking about can be fully addressed. So I think Royal College of Physician members will be paying very close attention to results of that vote, and perhaps more importantly what the college does and says following it. But before we finish on this, I just want to reiterate something that you said at the start, Nick, where we're discussing this because the rapid expansion of the use of physicians' associates is something that really concerns doctors, and because the introduction of PAs and the ARRS more generally represents a really big shift in the way general practice operates. But as you said, none of these issues we've been talking about are the fault of PAs themselves. They're very much caught in the middle of all of this, and this is probably not the sort of working environment or situation they expected to find themselves in when they began training to take on this role. And as you said, quite clearly a lot of these issues should have been addressed and discussed, in particular the scope of practice that PAs should be working within before this role was rolled out so widely across the NHS.
Yeah, I think another thing to mention here is that we've just mentioned new guidance from the BMA, new guidance coming from the RCGP, potentially some new advice from the RCP, some advice from NHS England. So reams of new advice still coming out, which is confusing not only for PAs, but also for practices and all the staff that work in them. And all of this coming when these staff already exist. And this is something that feels like it should have been dealt with 5-6 years ago before all of this happened.
Moving on, we've talked on the podcast before about the struggles that locum GPs have been having finding work in recent months as GP practices face increased financial pressure and are having to cut costs. But the problem is also affecting salaried GPs, with jobs in some areas being few and far between. Regular listeners to the podcast may have heard BMA England GP Committee Chair Dr. Katie Bramall-Stainer mention on last week's episode that she'd heard of GPs working as Uber drivers because they were unable to find a job. Nick, you've been looking into this a bit more for GP Online. What did you find?
Yeah, so I managed to track down the source of the story that Dr. Bramall-Stainer had heard about. I spoke to a GP who told me that a former colleague, also a qualified GP, has started working as an Uber driver because they just can't find work in general practice at the moment. The doctor working for Uber is a UK medical graduate who qualified as a GP 2 years ago, and they've really struggled to find work as a locum or salaried GP, which is a situation we've reported heavily on. Our surveys show many doctors are struggling to find work, and the BMA says thousands of GPs are currently underemployed. And from what I'm told, this GP weighed up taking on jobs in hospital as an SHO. So this is a qualified GP who's still looking for jobs outside general practice but within medicine, but decided to work as a taxi driver instead because they realised they could earn just as much money and felt there was less stress, less risk and more control over working hours in that job. The doctor I spoke to about this former colleague said that the GP who's now working as a taxi driver may well not return to medicine at all. It's hard to imagine a more powerful case that exemplifies the current crisis facing general practice. This is a doctor who spent a decade training to become a GP at great personal cost and with a significant cost to the taxpayer, who now just can't find work in general practice despite the fact that practices are crying out for more GPs because workload is heavier than it's ever been. The reason GPs can't find work, or as much work as they would like, is that practices are underfunded. The BMA says practice funding has dropped by more than 50% in real terms over the past decade and a half. And at the same time, a huge chunk of new money that's come in recent years has been ring-fenced to bring in other staff through the additional roles scheme. So practices are being pushed towards using those staff, but not funded well enough to bring in the core staff practices rely on, GPs and practice nurses, who don't come under the scope of the additional roles reimbursement scheme. And although, as I've said, a qualified GP deciding their best option for making a living was to become an Uber driver is a pretty powerful example of how GP jobs have dried up. But this came only a week or two after we reported on a GP being forced to use a food bank because they couldn't find work. I've also written this week about GPs cold calling practices to try to find work. And Dr. Bramall-Stainer, the GP committee chair, has referred to a disturbing paradox in general practice at the moment. Loads of GPs who can't find jobs despite workload in general practice being more intense than ever. If there's an upside to this, it could be that stories like this get noticed, and that could mean more pressure on the government to do something about it.
It's a really challenging environment out there, isn't it? And all this comes at a time, as you said, when we know there's a shortage of GPs and we're training record numbers of GPs at the minute. Last week, you also wrote about a survey the BMA had conducted among their GP registrar members, which, among other things, looked at their future career intentions. And it didn't really make for happy reading either, did it?
It really didn't, unfortunately. So this was a BMA survey of thousands of current GP registrars, and it found that just 38.4%, so it's less than 2 in 5, plan to work in UK general practice when they complete GP training. As you said, there are currently record numbers of GPs coming through GP training. It's around 4,000 a year now, compared with only about 2,500 a decade or so ago. But these figures suggest that there's a big question mark over how or whether that will translate into actually increasing the GP workforce. We know that the fully qualified GP workforce shrank by around 2,000 GPs between September 2015 and September last year. And that reduction in the GP workforce has come despite government promises to grow GP numbers. The government often says it's increasing the GP workforce, but it does that by quoting figures that include GP registrars. It says doctors working in general practice are increasing to avoid saying that GPs working in general practice are not. But if lots of registrars just don't plan to work in the NHS, then that blows that way of looking at the figures out of the water.
Do we have any sense of why GP registrars are feeling like this and why they're unlikely to take on roles in NHS general practice?
On top of the finding about whether they plan to work in the NHS, only 17% of GP registrars in the BMA survey said they felt positive about their future career prospects as a GP in the UK. I have to say, I'm not sure the content of our podcast is going to be helping on that front. But a really high proportion, 2/3 or so, had experienced symptoms of burnout, stress, anxiety and depression while working in general practice settings in their careers so far. So they're experiencing the intense pressure general practice is under firsthand before they've even completed GP training. And as the BMA said, it's a really sad picture. And when you add on to this the issues that we've been talking about with qualified GPs out of work, it's undeniably a real crisis.
What does all this mean in the long run, do you think? I mean, where are we heading? It seems totally ridiculous that we're training record numbers of GPs, which the government intends to increase even further under its long-term workforce plan. It's totally ridiculous with training all of these if they aren't even going to end up as GPs. We talked about the whole issue with international medical graduate GPs a few weeks ago, and some of the issues that means that they could be lost to the NHS. But this suggests that the problem is much wider than just IMGs, doesn't it?
Yeah, so as you mentioned, we've talked about the fact that half of doctors coming through GP training are international medical graduates who often need visas to work in the UK. And issues around that may be something that's contributing in this BMA survey finding that many registrars don't plan to work as GPs in the UK, along with some of the other factors we've talked about. Ultimately, what this means is that it's really clear that GP practices need a significant increase in core funding to be able to employ the GP workforce they need to deliver patient care. Practices are overstretched, but can't afford to recruit GPs, even though they're available, and more are coming through the system. So looking for a positive in this, there are GPs out there looking for work, and there is obviously a huge proportion of the GP registrar cohort coming through now who could probably be persuaded to stay if the conditions are right. So if a government were to come along with the will to hit a target of 6,000 extra GPs in general practice, it might be able to move towards that goal fairly rapidly, providing, of course, that the money and the will, like I say, are there to do that.
Before we move on, here's a quick word from our colleagues on MIMS Learning.
Like to keep up to date with current clinical practice? The Clinical Update podcast from MIMS Learning discusses a wide range of topics: contraception, cancer, climate change, COPD and chronic kidney disease, and that's just the C's. Join us every fortnight for expert interviews and key points from MIMS Learning's CPD modules, presented by our editors. You can find us on podcast players or at mimslearning.co.uk.
We talked a couple of weeks ago about the prospect of industrial action for GPs in England, and I also discussed the timetable we might be looking at around that with Dr. Katie Bramall-Stainer in last week's episode. And we'll come on to talk a bit more about where we are with that in a minute. But it's not just GPs in England that could be heading towards industrial action. GPs in Wales have also been talking about this. Nick, what do we know about what's happening in Wales? This has come from a vote at the Welsh Local Medical Committees conference, hasn't it?
The Welsh LMCs conference took place a week or so into March. LMCs voted for the BMA to urgently consider meaningful industrial action in primary care. So we could see moves towards industrial action in Wales as well as in England in general practice. The BMA in Wales said last year that general practice was at real risk of collapse. They'd called for a rescue package for the profession, but the calls that they'd put forward were rejected. And they said that the profession was under unprecedented pressure and needed a big injection of funding. And they gave up on talks earlier this year because the government wasn't prepared to meet what they were asking for. And in the end, the government in Wales imposed a £20 million uplift worth about 4.4% of the total value of the GP contract in Wales. So it's massively below inflation. And to be clear, that uplift is for 2023-24. So this is a massively overdue uplift to the contract for the current financial year, which is just coming to an end that we're talking about, not the deal for next year, which is what has triggered talk of industrial action in England.
Yeah, another thing from Wales that I wrote about this month is the latest workforce figures, which were also really interesting. I mean, the figures overall show there's been a 3% increase in the full-time equivalent, fully qualified GP workforce in the year up to September 23, which sounds quite positive, but there's really been a huge shift in the workforce away from partners to more salaried and locum GPs. Obviously, there's a lot less GPs in Wales than England, but overall, the full-time equivalent workforce increased by 50 to 1,592. But the number of partners fell by 72, which was a 6% fall. The number of salaried GPs increased by 68, a 22% increase, and the number of locum GPs by 54, which is a massive 62% rise. So you can really see a huge shift in the way the workforce is made up there. And at the same time, the number of practices fell by 8 during that year, and there are now 92 fewer practices in Wales than there were a decade ago. Those figures really reflect what you were talking there about the financial situation facing practices. The BMA Wales said it was unsurprising that the number of partners was falling given the current financial concerns practices were dealing with. It said it was really concerned at this growing trend of people moving away from partnerships. could ultimately impact on the continuity of care that the partnership model provides. There's real worries about what's going on there, which I'm sure really feeds into why GPs are thinking about industrial action as well. Nick, was there any other discussions of note that happened during that conference?
Some of the other motions that stood out included LMCs backing a motion calling on the BMA Wales GP committee to explore alternative models of primary care, because the Welsh Government hadn't provided the rescue package we just mentioned that GPs had asked for. So that sounds like we could be talking about a dentistry type model, for example. There were also motions passed raising concerns about practice closures, which you've just touched on, sustainability problems for GP practices and underfunding, and a warning that morale in general practice has been massively damaged by a decision to increase funding for community services but not for GP services in Wales.
Yeah, so moving on to England, we know the referendum on the contract deal for 2024-25 closes next week on Wednesday the 27th of March, and the GPC, the GP committee, will meet the following day to discuss the results. Do we have any sense of what might happen at that point?
We've actually got some early results from a GP Online poll of GPs. We asked about how people plan to vote in the BMA referendum on the GP contract, which is ongoing at the moment and closes on the 27th of March. So GPs are being asked in that referendum to say yes or no whether they accept the contract imposed by the government for the coming financial year. And perhaps unsurprisingly, of respondents who said they plan to vote in our survey, more than 95% said they would reject the contract. So if the BMA GP committee gets a mandate anything like that about the contract from the formal referendum that the BMA is carrying out, and as we've said before, the contract offers a 1.9% uplift to practice funding that doctors say is derisory and likely to trigger a wave of practice closures, then a mandate on that level could be a big step on the way to industrial action.
Obviously, we'll be keeping an eye out for the results of the referendum and any news coming out of that GP committee meeting next week. So do keep an eye on GP Online for the latest news on that. Remember, you can sign up for our email alerts to get the latest news and other resources delivered straight to your inbox. Well, that's it for this week. Thanks for listening, and thanks so much to Nick. I'll be back next week when I'm talking to Dr. Lucy Henschel and Penny Flack about how we can help GPs back into the workplace after they've had some time off, and why we need a more flexible approach to GP retention. It's a really good conversation, so please do join me then. In the meantime, you can keep up to date with all the latest news affecting general practice and access a host of other resources, including our popular Red Flags clinical series, on our website at GPonline.com.